Hello, everyone, and happy Canadian Public Health Week. We are glad that you could be here for this very topical discussion titled Housing and Health, The Way Home from Here, which is a collaborative session put together by the Manitoba Public Health Association in partnership with Bold Ideas in the Community Health Sciences Department at the University of Manitoba, the Canadian Network of Public Health Associations, and the Canadian Public Health Association. A very special thank you to the Canadian Public Health Association for providing the webinar platform and technical support today. Please note this session is going to be recorded, and so that others who are unable to join us can watch it later on this. I'm Nicole Herpa. I'm Secretary of the Manitoba Public Health Association and a PhD candidate in Community Health Sciences. Before we begin, I will acknowledge that although we are gathered here virtually today, I'm living and studying in Winnipeg, which is on Treaty 1 territory, where the University of Manitoba is also located. Treaty 1 is the original lands of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene peoples, and on the homeland of the Red River Métis Nation. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past and the ongoing present, and dedicate ourselves to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Please take a moment to acknowledge the land that you are on today as you join us. So in today's session, we'll be inviting our panelists to each speak for about 10 minutes, and then we'll have an opportunity for questions from our audience in a Q&A module at the bottom, as you can see. We're very grateful today to have Dr. Gino D'Estasio, who will introduce the panelists and moderate the session. Gino is a professor of geography at the University of Winnipeg and has worked in the field of housing for over 25 years. He actively teaches and conducts research into many aspects of housing, including the impacts of social, economic, and health on the market. He also led a very large study of mental health and homelessness in Canada. I also want to mention before turning it over to Gino that for those of you who are near here, next week, Wednesday, April 17th, we're going to have a public health meetup at Low Life Barrel House in Winnipeg, starting around 5:30, so that we can meet in person and have more discussions around this conversation of housing and health. Go ahead, Gino.
All right. Well, thank you, Nicole, and welcome everyone. It's great to see that our attendance, our participant numbers are actually moving up. So that's a good thing. So thanks all for taking time. I'll keep my comments pretty minimal, and we'll get moving to the panelists. We all know that housing is at the center point for many discussions as of late. A day doesn't go by when there's an announcement or a discussion about various form of a housing crisis that has really gripped the country from coast to coast to coast. So hopefully today we'll learn a little bit more between the intersection of health and housing, which is certainly critical. So I'll just read through the bios, and I'll let the speakers also give a little bit about themselves if they see fit as they introduce their points. I'll let everyone know that we're going to move as quick as we can, and hopefully wrap up right at 4:45 on the button. So keep your questions short and to the point in the Q&A button, and I'll sift through them as we get to that part, and we'll give our panelists some opportunities to see what they can how they can respond. So our first speaker will be Dr. Hee-Jun Chang, who is the medical officer with the Winnipeg Regional Health Authority. She graduated medical school in 2007 with an area of family medicine as a specialty. She went back to do a public health and preventative medicine residency in 2011 and has been working as a medical officer of health at the Winnipeg Regional Health Authority since 2014. One of her areas of work in public health focuses on today's topic, which is health and housing. Following that, we'll have Shannon Watson, who's the Health Services Manager and Lead for Homelessness in Winnipeg here. I won't disclose that I know most of the panelists, but we'll probably get to that in questions. So Shannon has worked with the Regional Health Authority as a Health Services Manager and Lead for Homelessness. She manages 2 teams working directly to assist individuals in leaving homelessness. Her role includes actions to address barriers in accessing health and social services that are required to support stability. Shannon has a master's in community psychology, and specializes on supports for individuals experiencing homelessness. With over 25 years of experience in the community and government sectors, I think we're very lucky to have Shannon, all our panelists, but certainly have Shannon here. Next is Christina Mays-Nino, Executive Director of the Manitoba Nonprofit Housing Association. Christina and the Manitoba Nonprofit represents over 25,000 units of affordable housing. I don't know how many people that would equate to, but I suspect 40-ish, who knows, maybe, I mean, probably more than 25, I suspect. So it's a lot of effort there. Also, the fact that those 25,000 units are spread out over 25 communities in Manitoba. The association builds sector and organizational capacity, advocates on behalf of the sector, and develops partnerships in the interest of creating sustainable, thriving, I like that, thriving nonprofit housing in Manitoba. And Christina certainly does a tremendous job in advocating and advancing the importance of the Nonprofit Housing Association. Mary Agnes Welsh will be our final speaker, and she is the board chair of Westminster Housing Society, and that's a position I held once. So I will say that because I was super proud to be a part of Westminster Housing Society. I think also a member of the Manitoba Nonprofit Housing Association. Proud member too. So Mary Agnes is currently the chair of the board of Westminster Housing Society, which builds and manages really good low-income housing in West Broadway and has been in the community, I think, for more than 25 years, for sure. And Westminster's latest project is a 21 unit project in partnership with Rainbow Resource Center, which is almost close, I think. Yeah, awesome. Looking forward to that. Mary Agnes is also, I did not know this, chair of the Exchange Biz District Biz, sorry. That's actually kind of cool. And on the board of Manitoba for the Arts and acts as a pro bono advisor on the Canadian Reconciliation Barometer. But on top of all that, her actual real job is a pollster. So you've probably seen Mary Agnes provide comments on all kinds of issues, often at election time. But she's a partner at Probe Research Inc., where she helps associations, nonprofits, unions, and government understand what the public thinks about big policy issues and maybe some little ones, right? Not always big, right? And why. So those are our panelists. So we are going to get this rolling. And Hee-Yoon, you're going to be up first. So I'm going to turn the microphone over to you. So thank you all for taking time.
Thank you. Thank you very much. Just give me a second. I'm going to share my screen. And then give me another second to put it into presenter mode.
And just as you're getting ready, I'll let people know if they do have questions that pop up. We'll get to questions at the end, but you can pop questions in as we're going. And I'll certainly queue those up for later in the Q&A period. So type away as you see fit. Okay, ready to roll.
Okay, so thank you. Thanks to everyone who's attending today. I'm getting us started by talking about housing and health, how they're linked, and how important housing is to health. So first of all, what do we mean when we're talking about housing? When we think of housing, we usually think of the structure of the housing. But when considering how housing impacts health, it's not just about the structure, but structure is important too. Housing quality does impact health. But housing is also what I'll just call the circumstances by which a household is housed. Do they rent? Do they own? What are the terms of their tenure? How much does it cost? Who's responsible for maintenance? And housing is also what I'll call the housing system. So if a household was seeking housing, and when I speak of a household, it might be just an individual, it could be a family, it could be any other unit. But when looking for housing right now, what are the existing options and that could be bought or rent or etc. And just as importantly, what steps do they need to navigate in order to even begin to try to acquire available housing? And unfortunately, many of the options available in our housing system do not necessarily match the needs of the population, which is a source of inequity, and this impacts health. One huge barrier to health with respect to housing is affordability, or what I should really say is housing inaffordability. Households on a limited income will have much fewer options of places to live, and this can directly and indirectly negatively impact health, especially if this is long-term. So we can consider the consequences related to housing inaffordability in terms of cost, housing quality, the consequences of overcrowding or housing instability. So first of all, when talking about cost, housing inaffordability is usually defined as when a household cannot pay, or sorry, a household is paying 30% or more of their total household income to continue to live in their current housing. And this housing inaffordability is considered severe when half or more of the household income is going to paying to live in the home. And generally, we're talking about households that are living on a limited income. The cost to stay housed is not negotiable. If you cannot pay for your housing, you cannot continue to live in it. So that means housing inaffordability risks not having enough to pay for other basic needs like food, medications, other care, adequate clothing, communication needs like phone, internet, transportation. And I'm sure you can think of many other things. And it causes stress to all those living in that household. The consequences to health of this are easy to extrapolate. This can cause problems, undernutrition, neglect, or worsening of chronic diseases. Housing inaffordability is associated with lower self-reported health. There's disruption to health services. All this can have negative consequences to mental health, mental wellness, and children raised in housing situations like this can have adverse effects in their childhood development. Housing inaffordability may cause households to have to live in housing of lower quality. This is an aspect of housing where the potential health risks are fairly well understood and delineated. Housing of lower quality can cause thermal discomfort, not warm enough, or in some cases not cool enough, such as during a heat wave. Housing of less quality can be damp, leaky, have poor ventilation, have mold, increases exposures to known health hazards or to infestations, which also have health risks. It can be in poor repair. For household members with disability issues, it may not have adequate accessibility. Some housing it does not even meet safety codes, and that obviously has safety risks. And anyone living in household situations like this may be subject to stresses. The consequences of lower housing quality would also include can specifically include increased risk of allergies, respiratory symptoms, cancer due to certain exposures, injury, or inability to escape during an emergency because of unsafe repair or not meeting codes, fire risks, and of course, and many other health risks as well. This all impacts mental health, mental wellness, and children may experience adverse impacts on their development if raised in housing of lower quality. Housing inaffordability may cause households to double up or even more when leading to overcrowding. One caveat to this is there is some cultural variability to what is considered enough space, but we're talking about when overcrowding exceeds health expectation, and this creates health risks due to crowding and also due to an inability to be able to rest or heal when needed. And anyone living in overcrowded household situations will experience stress. One of the best known health consequences due to overcrowding is the easier transmission of infectious diseases, but overcrowding can have impacts on other chronic conditions as well, including chronic disease, mental health, mental wellness, and there again adverse effects on children growing up in overcrowded settings that can impact their development. And in some cases, not all, overcrowding may be some housing situations that are overcrowded may also be unsafe. Housing inaffordability may decrease the stability of housing. This could be potentially due to no longer being able to pay for the housing or to the precarity of the tenure over which many households have little or no control. Health risks associated with this are the consequences of living under constant threat of eviction or due to frequent moves, which disrupts regular other activities like work or school or regular services, including medical care. And households living in a state of housing instability also experience stress. Consequences of this can affect every aspect of health. It is also associated with lower self-reported health, but also disrupts regular health services, affects mental health and mental wellness, something I've mentioned with every risk. And again, children and youth are at particular risk growing up with housing instability. It affects all aspects of their health. So housing inaffordability does have direct health impacts, but it also has the ability to negatively disrupt all the upstream, many of the upstream social determinants of health as well. And even with some of the unchangeable social determinants of health, like gender and race, these may have an effect on, this may create vulnerabilities in certain populations that create housing inaffordability issues. Of course, we do have to keep in mind health risks also don't exist in isolation, and different households have different capacities to respond to various exposures. So we can't talk about housing and health without also talking about homelessness. Homelessness itself has many health risks. And any pathway to homelessness is therefore a health risk. Obviously, affordability is one pathway to homelessness. But besides affordability, there may be those in the population for whom attempts to acquire housing are even more difficult, not just an affordability issue. What I'll refer to as primary homelessness, this is sort of a term I just created. I think would include those who have never even been able to enter into the housing market or the housing system, if you will. And this could be for reasons of not having needed credentials or life skills or connections or any other privileges that allow to begin seeking housing at all. An example could be youth at risk or youth aging out of care. But even among those who were previously housed, and I'll just refer to them as sort of secondarily homeless, there are many possible reasons that households may unexpectedly lose their housing. And in many cases, and for some, they may be in situations where seeking new housing is beyond the resources and capacity that they have. And this could be due to inequities or complexities of the housing system, or both. All of this is health risks, as homelessness carries health risks, and any episode of homelessness risks chronic homelessness, which has even greater health risks. The state of homelessness is a very negative experience. It's also attendant with physical dangers to the elements, violence, exploitation, particularly to those at risk. In the state of homelessness, it's difficult to meet basic needs, or you only spend your time meeting your basic needs. Don't have stability or ability to make long-term plans, and it disrupts regular activities. Chronic homelessness is where the state of homelessness is prolonged. In Canada, this is defined as at least 6 months in the last year, or periods of homelessness in the last 3 years. But in reality, many who are chronically homeless may be homeless for years or even decades. The impacts on health get increasingly complex and severe, so much so that chronically homeless are estimated to experience a lower life expectancy. One study, it is a Canadian study, did estimate this to be as low as 42 years for men and 52 years for women. And obviously medical issues may remain undiagnosed or untreated. I'm going to completely shift gears now, and just to briefly talk about some category I'm calling housed but not healthy. As I indicated at the beginning, housing isn't just about the structure. Even if securely housed, many households may need additional supports to be able to maintain the housing and to thrive in that housing. Another situation that I haven't mentioned, which is important to mention, is that many members of society may end up staying in unsafe living situations. It could be an unsafe household, such as a household of abuse. This particularly affects women or youth or children. And I haven't talked much about older adults. Even if securely housed, older adults' needs can change over time. They can experience increasing social isolation, which has a lot of negative health impacts. Some older adults may experience decreased ability to maintain their current housing. At its most extreme, this could they could be living in squalor, which has many negative health impacts, or their accessibility needs may change over time with their physical needs. With proper supports, older adults could thrive at home. This is my last slide. I felt my presentation had been fairly negative, and I'm trying to end on a positive note. Housing is a human right, not a commodity. Where housing is affordable, secure, of good quality, where supports for household members are provided or are present, and where housing is accessible and the household members feel a sense of connection, the home can be a place to rest, to keep your things, to thrive, to grow, and to grow old. And that was my last slide.
Excellent. Thank you very much for setting a really solid context for us. So we're going to shift over to Shannon now. And again, for those that joined late, if you do have questions for any of the panelists, you can start typing them into the Q&A, and I'll keep track of those, and we'll come back to questions once we get through. So Shannon is ready to roll. Okay, so you got 10 minutes. Thanks.
Are you seeing it in the right view, Gina? Great. Okay, thanks for having me here today. I appreciate you ending on a positive note there, Hejun. I know that we've worked together on trying to figure out how to support a lot of these pathways towards supports because of all those issues related to the impacts of houselessness and different housing challenges. So lots of good work that's happened. My first slide is potholes, so also kind of a negative view, but I might seem somewhat obvious to those who are doing this kind of work all the time. But not everybody in their roles has the opportunity to support individuals in a way where you can take time to build relationship and talk to collaterals and get a lot of information about history. But I wanted to kind of emphasize this point when it comes to talking about what kind of supports are going to be needed to support somebody in housing, because it's really valuable to understand what has their experience been like in housing before, if they've had that opportunity to be housed, and to learn what some of the things were that tripped them up. What are some of the potholes that led to eviction or housing loss? Because that can be very diverse. And it really helps us to plan for what is the right combination of supports or the right level of supports going forward, because every housing loss experience gets internalized as a failure. And all of those failures can really lead to hopelessness. And we need that hope in order to support somebody to move forward. The other kind of framework slide that I wanted to emphasize is related to the stigma that can develop or damages, can get labeled as bad choices. And we want to shift the frame to think of it from a trauma-informed perspective and understand some of the experiences that people have had. Some of those experiences are related to colonization and trauma and stigma. And if we shift the frame to think about what people have been through, some of those reactions and some of those behaviors that have been challenges in housing could be a result of trauma or a symptom of trauma. And so if we shift that frame, we start from a different perspective in terms of forming collaboration with the person we're trying to support. The next focus is a model that we've created with the team that I've been working with for the last numerous years. We call this approach CHIP, and we always take this into consideration when we start working with somebody before they even get housed, because there's so many supports that could go into successfully supporting somebody in housing. And the foundation seems to always need to include case management, somebody to do housing search. That may be the case manager, it may be somebody else. We always need income in order to pay for housing. And it's fascinating how many times we might start housing search before we even know what the income source of the housing budget is. And then primary care to assist with some of the health related challenges that might come up in housing. And I'm going to get into these pieces in more detail. So even though there's no words on this slide about case management, I feel like this is the one slide that is most important to me. And it's because case management is such a general term. It can mean something different to so many different people, and every program operationalizes it differently. So we break case management down into describing it as either high, moderate, low, or minimal. And when we break it down like that, we're thinking of things like how often can the case manager visit? Will they do home visits? Will they support people to get to appointments? Will they be able to help somebody in their unit to address some of the challenges that might come up with a landlord or lead to eviction? And case managers may be as intensive as visiting every day to never visiting in somebody's house. So thinking back to those potholes, we want to think about what's somebody's history been, and then ensuring that the case manager that we're attaching is at the right level of intensity to support somebody to be successful. If somebody's going to need a weekly connection, somebody visiting them, helping them negotiate with their landlord, taking them to appointments, we don't want to attach them to a lower level of intensity, even though the lower level of intensity might be the program that says yes first, but we want to attach to the program that makes the most sense. In speaking about that, I want to highlight housing first, because in Winnipeg, at least, and it may differ slightly in different cities, when we think about who can provide case management at a fairly intensive level, we often partner with our Housing First teams, because Housing First will not only help somebody access a unit and move in, they'll stay connected longer term, they'll visit a minimum of once a week, they'll support with landlord connections and integration into community. They can fluctuate as different things come up for people in their lives. And so partnering with a Housing First team or getting somebody connected to a Housing First team might be a good option. One of the things that I encourage a lot when people call me about what are the options or where can this person go, is they're often thinking about specialized buildings and places. And I often try and discourage that approach and start thinking about the broader market, the public market, the private market. And those, Christina's going to talk to us more about that next. But if we don't focus in just on the specialized supportive housing models that have staff in place, our options for housing get quite broad. And when we think about those models, we want to think about, okay, if the supports aren't in place, aren't in the building, we have to plan for all of the aspects of living in a unit and what are the tasks or things that an individual might need support with. And then we have to plan for who can provide those different areas of support. It's just about thinking about a person as having a whole bunch of responsibilities, but then let's plan for who's going to do the rest of those tasks. When we do that, there's not very many programs that I'm aware of anyway that would say, oh, we can support any one of the things that an individual might need support with in housing. And what happens often is a program that is connected will feel like this person's needs are too high, I can't support them adequately, so I need to refer and close. And what we want programs to consider instead is layering in other supports, bringing in other programs, creating integrated plans of care, and partnering to deliver support so that all those different areas get supported adequately and the person feels like they have a team around them. When we have multiple teams in play, it's really important to be doing lots of communication that might require system meetings, might require different fluctuations in who's doing what as crises evolve. And a lot of times you really got to figure out like who's the primary case manager, who's going to hold the plan together when there's a lot of different players involved. Some of the top 3 challenges that come up when we're trying to do this kind of integrated support planning would be experiences where the person doesn't necessarily engage. You might have aspects of support that you can't figure out who's going to fill that role. And there might be concerns about going into some of the buildings where people live around related to risk. So in terms of engagement, this is where I really want to emphasize a trauma-informed approach and just recognizing the amount of time that is important to take for building relationship and trust, and not necessarily going in just with these are the 3 services that we offer and expecting the person to say yes right away, but figuring out like what is it that that person would find useful that day. And doing something practical is often the way to get over that hump, helping somebody to see you as somebody who can be useful in their life and building that connection to get you through the door. And sometimes that's difficult to do. You might not get over that. And so what we want programs to consider is if it's not you that's going to stay connected, before you close, figure out who takes over from there, because we want to ensure that somebody's not left with nothing because it didn't work with your program, it wasn't a good fit. So we kind of ask like, if not you, then who? What's the handoff? Who's going to take over so the person's not alone? And then the last slide is just related to thinking again about some of the questions that come up around providing support in people's homes, and risk gets flagged sometimes. So we want to, there's some strategies that we have in terms of breaking down what might feel like risk on the surface. If we really piece it apart, there might be strategies that we can put in place that take away some of those feelings of concern about risk, and then just tackling the part that is more specific, because we usually can still find ways to go and visit in somebody's home without feeling like the whole building is not a safe place to go. And because I don't have a whole lot of time, I'm not going to go into that in any more detail. Who can assist, talking to teams that are able to be mobile and go out and provide maybe clinical support. It's interesting how much support primary care providers can provide if somebody's really struggling, because there might be an underlying health issue and we don't often think about looping in primary care providers to assist with that. Using agencies that are really flexible in their approach, and considering informal supports as well, as people with relationship are often the bridge to helping us get over some of the humps. And that's it for me. So back to you, Gina.
All right. Well, thank you so much, Shannon. Again, lots to take away from that. I'm sure we'll have some really great questions. I know I'm frantically writing things down too here, so really great. Okay, so we are going to shift over to Christina and let you share your screen and get rolling. So again, if you have questions, make sure you start typing them into that Q&A section.
Thanks, Gino. And my slides are good. You can see them. All right. Thank you so much for having me today. I'm actually at a national housing conference, so I'm joining you from Fredericton, and I was practicing the land acknowledgement, but I'm going to say that I may butcher the names of the First Nations that I'm joining you from today, but I am joining you from the traditional and unceded territories of the Wolastoqiyik, Mi'kmaq, and the Pesto-Wakakti peoples. And so I love being in a room full of housers, and I'm really excited to be in a virtual room with people in the housing and the health sector, because we know that there's so many relationships between health and housing, as Dr. Chang, of course, talked about. So I'm going to be talking about social and affordable housing, including defining those, because often we're not talking about the same things when we're talking about social and affordable housing. What are the gaps and the needs in social and affordable housing? and some solutions to meeting those needs. So slide isn't moving forward. There we go. So this slide is the housing spectrum. And the slides that I'm going to be presenting, the next three come from, this is what Canada Mortgage and Housing Corporation uses to show what the housing spectrum is. I'll talk about some flaws in this model, and I'll be borrowing some slides from the Community Housing Transformation Center, who have done a great job of explaining some big gaps in the housing market and why we are in the housing challenge and housing crisis that we're in today. So this, I'll go through some definitions for you. So transitional housing is a programmatic housing. It's usually 2 years or less, and you're in transitional housing because you are agreeing to be a part of a program. So there's a range of different ones. There's transitional housing for people escaping domestic violence, transitional housing for newcomers to Canada, for people leaving addiction. So there's a range of different reasons why people might be in transitional housing, but there's always a program attached. Social housing in Manitoba means housing that is funded by government, by Manitoba Housing, to fall under the social housing agreement. They follow some rules on that, and they provide rent geared to income housing. So the housing is always affordable. It is tied to the income of the tenant. In some places, in other provinces or other countries, social housing may mean something different. Sometimes it just means housing that has some government support. It's not always a rent geared to income model. But in Manitoba, it does mean rent geared to income. Affordable rental housing has so many definitions that we could spend a whole day talking about the definitions of affordable housing, and we will not do that. The main thing about affordable rental housing to know is that when you see affordable rental housing being described, being announced, look at what are the rents, who are they affordable to? So affordable rental housing sometimes means private market housing. Sometimes it's in that poor condition that Dr. Chang talked about. Or sometimes it's affordable because they're receiving some government subsidy to bring the rents down below market, but not necessarily tied to the income. So always look at the definition when we see affordable housing. Affordable home ownership is home ownership that's usually through it's made affordable through a philanthropic or a government program. The best well-known one is Habitat for Humanity, where households can put in some sweat equity as well as volunteerism, and then they don't have to pay the same down payment and get a more affordable mortgage, so they can afford to purchase a home. Market rental housing is housing that is tied to the market. It's owned by individuals. Sometimes it could be someone who has a unit that they rent out, or it could be a large mega corporation that owns thousands of units. So there is a range of market rental housing, but the cost is tied to the market. And that's similar for, market home ownership it's tied to the market, and we purchase it, and individuals own it. So ownership does vary across this spectrum. So this is the community. Generally, the half on the left is owned by community housing. So you might hear the term community housing a lot. Community means it's owned by government, by nonprofit, or by co-ops. So it's owned by some sort of community entity. And then there's for-profit housing. And so for-profit housing is owned by individuals or businesses, and it generally is on the market. There's some gray area. This shouldn't be a straight, it looks like a line straight down the middle. Actually, community housing organizations do often own affordable rental housing. Co-ops may not be social housing, but they are affordable. So there are some gray areas in here, but that's generally the definitions that we use. And some flaws in this model that are important to just to keep in mind. There are three major ones. One, it looks like a continuum. It's not a continuum. We don't move, left to right along a continuum. Some people will live in social housing their entire lives, and there's nothing wrong with that. So there's nothing positive or negative necessarily, except for on the far left, homelessness and emergency shelters are not housing. They're not part of the housing continuum. They are experiences where you don't have housing. Again, the lines aren't as clear cut as the model makes it look. And the biggest flaw, I think, in this model is that it makes it look like we have these even slices of the market for each of these areas. But actually, on the left-hand side, so community housing is actually only 3% of the housing in Canada. And the other 97% is privately owned. So we have a very small portion of housing that is owned by the community that is affordable. And that is creating a lot of those affordability challenges that we're seeing across the country, including in Manitoba. And so this is just, this is a oversimplification, but just to, it helps me to think about who is living in the housing. And so this is the income capacity. So the higher the income you have, the more likely you are to live in market home ownership. And these are the support needs. Again, a simplification. Some people experiencing homelessness aren't actually accessing a lot of support, but generally the support needs are higher. And in the middle, there's this gap too, right? Like the income capacity is lower, support needs are lower, but we don't have a lot and actually that population is higher, and we don't have a lot of housing that's serving that population. And this is where the resources are going. So the resources in Canada and in Manitoba that are going towards housing and homelessness, I think we often think about and talk about more and more the resources going into homelessness, into emergency services. Again, you have to take this with a bit of a grain of salt. There are individuals who experience homelessness who are not accessing any services, who are not costing the system money and are struggling very much on their own. But in general, emergency services are costing us a lot as a society. And we don't think about that other side of the spectrum, that market home ownership and market rental housing also receives significant public investment. So market home ownership, we provide about $10 billion, that's billion with a B, in tax exemptions for home ownership every year. And that doesn't take into account the environmental costs and the infrastructure costs, the infrastructure that we put into private rental and home ownership. So there's this big gap in the middle. Why is there this big gap in the middle? This is a chart showing the federally supported, federally assisted social housing across Canada from 1946 to 2019. You can see there's this bump in the 1960s when the government started investing. At the beginning, it was very much in public housing. And then towards the 80s, it moved more into supporting nonprofit housing. And in the 1990s, early 1992, you see this massive drop. So we are not building community housing, even now with the National Housing Strategy, at even half of the level that we were in the 1980s. So we're falling further and further behind in terms of the community housing that is available and in terms of the proportion of housing that is available. So some other things to know about this graph and what it says about housing is that we have a fair amount that was built from the 1960s to the 1980s, not enough. But we have this housing that was built, a lot of nonprofits in Manitoba. You may not, I didn't realize until I started at the Housing Association, there are about 200 nonprofit organizations across the province providing affordable housing. And they tend to be very small organizations. And they have a lot of experience. They were built in the 1980s. That means they're, I want to say 1980s, they're 20 years old, but that's not true. They're 40 years old. And so they are older organizations. They have a lot of experience. They know what they're doing. And what that also means is the buildings are older. So the buildings are 40, 50 years old. That means that they're in this period of needing investment so that they can serve the next generation of folks who need them. So what do we need to do about this? The nonprofit housing sector together has some shared priorities that I'll speak about. There's 3 of them. The first is very much based on the existing housing. So we can't afford to lose the existing housing that we have. If we lose that housing, we know it will cost at least 4 times more to replace that. We need roofs, we need HVAC systems, we need to modernize that housing to serve the next generation, which might mean changing the structure and the expectation. People have different expectations of their housing. Sometimes, you know, we need electrical upgrades because people have more things to plug in than they did in the 1980s, for example. And so we need about $1.5 billion in capital funding over the next 10 years to get our housing up to a good standard. The other big thing, and Shannon talked a lot about this, is the support aspect of housing. So community housing is not just a door and four walls. The folks who are moving into community housing are often there because they have lower incomes and sometimes support needs. And so we need tenant support within those buildings. Sometimes it's as simple as having one person who works in an organization who can help people fill in the forms, who can help build trust because people have lost trust with landlords, who can call them and say, hey, I noticed that you haven't paid your rent this month. Is there something I can help you with? So sometimes it's that simple. And we also need more supportive housing. So we need folks we need more buildings where there's 24-hour supports on site for those that have more intense needs. And then the big thing that we talk about all the time, but needs repeating again and again and again, that we need more community housing. How much do we need? We need 10,000 units of community housing over the next 10 years, or about 1,000 per year. Our current budget, the budget that just came out, is going to be supporting about a third of the need, 350 units this year. And we know that for the past number of years, we weren't building any community housing. So we keep falling further behind in terms of meeting the need. Economists, Scotiabank put out a report saying, of all organizations, so that we need to double the community housing stock across Canada over the next 30 years. And so if we were to build 10,000 units in over 10 years, we would be on track to meet that target. You'll hear a lot of the private sector folks talking about supply. We agree we do need supply, and part of that supply, this 10,000 units, is the community supply. So it doesn't take into account the private market supply that we also need, but this is the community-owned housing that we need to actually start to address those affordability and quality challenges that you heard about at the very beginning. And we need, in the housing sector, we need allies like you in the health sector to help us share this message about how important it is to the health of our individual households, but also our communities and our society to have good, affordable housing. So thank you for joining us to learn more about that today.
Wonderful. Thank you so much, Christina. Really good. Again, I'm filling pages of notes here. We've got a lot of work to do. We've got to build, as you say, 10,000 units of affordable housing on top of the, tens of thousands or even millions of units that we need across this country. So we're definitely in a bit of a pickle here. So we're going to turn it to Mary Agnes, who's going to start building, chipping away at those 1,000 units from her Westminster Housing chair. Mary Agnes, over to you.
Good. Thanks, Gino. You'll see I'm the only one without a PowerPoint because I'm not quite that organized, and also because I wasn't entirely sure what I was going to talk about. But in fact, the thing I do want to talk about is kind of a perfect, maybe, I hope, kind of street level housing provider view of all of these kind of key issues that folks have raised today. But before I kind of talk about that tension that we're struggling with a little bit at Westminster Housing, I thought I'd tell you really quickly a little bit about us. We have about 30 properties, mostly in West Broadway, which is my own neighborhood. And traditionally, we've bought and rehabbed old rooming houses, so made sort of 2-unit, 3-unit kind of buildings out of old rooming houses. So there's been a little bit of community revitalization that's also happened as we've bought up properties over the last 20, 30 years. And our tenants tend to be very, very low income folks. So folks on welfare disability, the working poor, some newcomers, but they don't tend to stay with us very long because they have maybe access to different supports. And when we do a tenant survey, which we do every once in a while, we know that about 1/3 to 40% of our tenants are Indigenous people, Many have disabilities, and most are, all of our units are subsidized pretty much. There's a few folks whose income goes up and they fall off subsidy, which is actually a good thing. But almost all of our units are subsidized. So we really do house the people most in need. But we don't, and we struggle to house people that are genuinely transitioning out of homelessness. And we struggle to provide more than a door, more than four walls, more than a structure. I think for the last very many years, we've really been focused on the structures, build more, get the money, do as much as we can, sort of leave some of the social worky stuff to those kinds of folks who can do it better than we are. And we're finding more and more that that's just not working. And that gets back to that notion of sort of housing as a system and housing as kind of part of a whole healthcare continuum. And so we're really struggling with that, to be honest, as an organization, especially as Christina's cool sort of federal funding graph doesn't go too far into now, but like governments, I know it's not enough, but governments are kind of throwing money at housing providers with a history of being able to build stuff to try to increase supply. So we are so focused on trying to grab that money and build more, like we are at our Good Street project with Rainbow Resource Center. We got rapid housing money for that, and they were just like, please take 5 million and get started right away. And we were in a panic to figure out sort of how to do that and how to build a relationship with Rainbow and create that structure that would give our tenants some of those supports, not quite crisis intervention supports, but definitely some kind of social work, community sense of community, a bit of therapy, that kind of thing, something that would help keep people housed. So we're getting all this money to build new, but we are struggling with keeping people housed, trying to respond as best we can to the homelessness crisis, and maybe taking honestly risks on tenants that we might be nervous to take in as a tenant because they are maybe higher needs, kind of higher on that support needs graph that Christina had. And we've had, I'll be honest, some fairly negative experiences trying to work with local social service agencies and support services who just sometimes aren't quite there with us when there is a crisis in a unit, when somebody is having a mental health crisis or is maybe an older person letting some unsavory characters in through the back stairwell, and creating all sorts of havoc and really making life hard for other tenants, for the single mom downstairs. We run into that a lot, and we've really struggled in the last 2 or 3 years to find that balance between what services can we realistically offer or kind of organize for a new tenant, and what is just it's just beyond our ken. We need to stay in our lane. And so I think that's kind of one of the on the board at Westminster and kind of in our own community, we're all kind of grappling with that, trying to think in a much more holistic way about housing and try to figure out who can do what and how do we keep an increasingly hard to house cohort of tenants housed in our units, and try to keep things kind of running smoothly and being healthy, friendly places to live, and trying to struggle with some of the financial implications. A tenant who does have maybe a mental health issue, or is experiencing some hoarding tendencies, or is perhaps having a substance use situation where they cause $20,000 worth of damage to a unit, which is a hard thing for a nonprofit housing provider to kind of manage. And so as we're trying to find this balance, I think we're struggling with a lot of these pieces that I think everybody else has talked about today. And so so I think that's kind of our next challenge as a board. How do we keep building new stuff? What's our next project after, we're at 121 units now. We always just want to build more, but just building more is, I think, increasingly clearly not enough. And so building those relationships with social service agencies, some of those support services, WRHA. We've had the Hawks team out for some tenants who have been really struggling. We've kind of dipped a toe in some of those services. And we do have a tenant outreach worker who has kind of a social work, kind of this much social work kind of aptitude, but is just one person and is building relationships with tenants and can do a lot, but can't quite organize a whole wraparound series of services for a tenant in crisis. So we're really grappling with all of these challenges, I think, at Westminster. That's kind of a downbeat note to end on here. I think we're all maybe a little bit, there's a lot of challenges in housing right now, but I think the one good thing is like a wave of money to build new that Christina will say, it's not enough, totally not enough. But there was nothing during the PC government in Manitoba. We couldn't even get subsidies for 2 new units. There was very little new funding, and there is now money to build new, but we got to get those services to catch up with the new units and the the new inventory that we are able to build. So I'll leave it there, just watching the time. I want to make sure I'm not talking too much.
No, that was great. Thanks. And I know, Mary Agnes, there'll be some questions here popping up. So I'm just going to take just a short pause to say thank you to all 4 of our panelists for sharing a range of expertise that I think when you put it all together, we've got some pieces here that really speak to the complexity of providing housing that is affordable, that provides access to supports, and at the same time promotes that sense of well-being and wellness within the housing unit. So just looking through the chat and through the Q&A, there's not a whole lot, but there is one here from Jessica, who really speaks to some of the challenges in housing individuals, which I like to use the term complex tenancy histories, whether it's hoarding, mental health behaviors, bad credit, just a whole host of challenges in their residential history. Shannon, I don't know if this is one for you to sort of speak to, but how do your programs kind of work with tenants that have a really complex history?
Mm-hmm. Sure, I can try and respond a bit to that. So because Jessica's identified that she's with the community mental health program, like that gives me a little bit of an indication of what some of that struggle might be there too, because it would fall within that role to support housing access, but related to what I was talking about in terms of acuity, she would have a really, really large caseload. And so having the time to take to support somebody to go to viewings, to talk to landlords, to try and convince a landlord that what those problems were before are being addressed with a different level of support now is going to be part of the challenge. And so one of the things that we often do with our partners in community mental health is talk about what other supports can we layer into that, because the person that Jessica's describing might need somebody who can come and do some home visits, maybe support some of the things that are happening in their day-to-day functioning in their home in order to keep some of those concerns of the landlord at bay. And that would exceed what Jessica and her program would be able to do alone. And so this is where I might point again to like a Housing First team or another team that might be able to partner. It's not about one or the other, it's about both and. And if we add in the supports, we might be able to say to a landlord, well, yes, those were concerns before, but with the person's consent, we can talk about here's the different layers of support that this person has now. And we have a plan for addressing those concerns that came up in the past.
Excellent, thanks. I don't know if any of the other panelists want to offer anything to that question. Good, okay. Well, Mary Agnes, here's one for you. Can can you talk a bit more about the partnership with Rainbow Resource Center? Maybe just a bit of a background. How did it come to be, and how were you able to sort of, I guess, pull all that funding together to get those shovels in the ground?
Yeah. Truthfully, minor nightmare, if I'm being honest. The partnership came about because the city of Winnipeg was a little bit desperate to get rapid housing money out the door, and we knew we could get some of that money if we had a partner that had a bit of a more unique need. It's not good enough to just build low-income housing; it needs to serve a particular need. And truthfully, that's how Winnipeg, being Winnipeg, we kind of knew the folks at Rainbow a little bit, and that's how the partnership began. And it's been one of the most, I think, rewarding, educational, valuable partnerships that Westminster's ever had. It hasn't been easy. We have sometimes different kind of approaches to the project, and and the kind of the relationship. And it's a little bit sort of technically messy for a whole bunch of complicated subdivision land title reasons. But it is, we hope, an opportunity for us to step forward in providing the kind of housing that does come with on-site supports. Not super wraparound, but definitely way more than we can offer most tenants. And this project is specifically geared towards older, low-income adults. And we have 7 units that are also geared towards people that are really highly at risk or kind of coming out of homelessness. And of course, they have to be LGBTQ2S+. So it's got quite a narrow focus, but we're just about to start intaking. I think we're already intaking tenants for kind of a May 1st first round of folks, getting a new apartment. And so it's catapulted us forward in what we can offer tenants, but also our own skills as volunteers. We have one executive director, and the rest of us are volunteers. So it's really been a terrific opportunity for us.
Excellent. I see one question here that's a little bit close to the work that I've done, close to my heart. Anybody have any thought? Now, the question is, any thought on taking down SRO, single room occupancy hotels, and rebuilding affordable housing? But anybody want to touch on either renovating, redeveloping? Anybody want to pick up on the SRO question and where an SRO might fit in all this? Go, Christina.
I could. I think the SROs is, I know I've heard Gino say this many times from the research that you've done, and it's been demonstrated many times that SROs are a choice for some people, and they are not necessarily a negative choice. And so there are folks that are living in SROs who would otherwise be experiencing homelessness. And so just taking down that housing without replacing it or without something else would be a huge problem. We would have hundreds more people without any housing options. There are different models that have worked really well. BC Housing is often buying up existing SROs and turning those over to the nonprofit sector and turning that into supportive housing. The Bell Hotel is an example of that here. So that was a partnership model that purchased the existing single room occupancy hotel, made substantial renovations, now has supports on site. I think each building needs to be understood on a case-by-case basis. So the Bell Hotel I've read would, maybe would have been more affordable just to tear down and turn into a building that would meet the needs of the population better, because renovating an existing very old building sometimes is much more complicated and expensive. But we need to preserve those units, and we can't just tear them down. So I don't think that the question was arguing that we should get rid of them entirely. They are, although they are providing homes for people, many of them are providing very undignified, unsafe, and unhealthy homes for people. And they are a choice between the streets or shelter, and which often provides very limited independence for people, and a place that people are paying their rent. So we shouldn't be accepting them as they are. We shouldn't be allowing folks in our community to live in those conditions the way that we do. But they would need substantial investment to replace all of those units.
Excellent, thank you. Now, another question here, just sort of, I think, is going back to Dr. Chang, some of your comments about health, and Shannon, some of the work that you're doing with respect to the services, quality of housing, and it's actually now playing off of this comment about SROs. So how do we find this balance between adequate, healthy housing and dealing with sort of the shortfall? So we've got people in SROs, or we've got people in unhealthy housing. What do we need to do as a panel here to try to address that question of quality, health, and housing? I'll look to Dr. Chang first.
Yeah, I mean, that's a tough one. Like, to start off with, as it's been mentioned, right now, there isn't the housing that is available isn't meeting the population needs. So there is, so one of the first problems is there isn't enough housing, and people are settling for less or not being able to find housing at all. To a certain extent, regulating the quality of housing can help maintain standards. It's challenging to do that. As with every other aspect that's sort of been discussed today, that needs more resources. Having better supports or having, sufficient supports for people who need it to maintain the quality of the housing as well, and that some of the others may speak better about some of that to some extent, may sort of allow some ownership over the space, allow people to thrive within those spaces, and make them healthy spaces for everybody, and for for them and for the others living around them. So I think there's a lot of different aspects of the community, as well as regulation, as well as just making sure that the housing that is made available within community is meeting the needs, so that we need to reflect the community needs. So not sure if I've answered it in a clear way, but I think there's a lot of different variables here.
Yep, and I'm just going to frame something, then I'm going to open this up for our last couple of minutes, because we do have another comment from Julia, who's talking about kind of the transition, talking about some didn't whack today. So again, it's as we're working with individuals to get people into more stable housing, sometimes the challenge from shelter or others, as Christina said, that next step might be into an inadequate SRO. How do we break this cycle then of transitioning individuals, getting individuals from unsheltered, precarious housing into stable housing that promotes well-being? I'm looking at Shannon now. Shannon, it's on your shoulders here.
Oh dear. Okay.
No.
I've been looking at Julia's question and trying to think about a response, and I think it's sort of multifaceted. I mean, there's a piece of it where it's identified that folks might be going from shelter into SROs. And if they're connected to somebody who does housing search, there's sometimes that is a bit of a strategy for somebody who has a really poor rental history or no rental history, because it, like, despite the challenges that we're all very aware of, you could say is a really low barrier, and that's being generous. So if somebody can get in there, I think the key is to sort of keep working with that individual to build hope that they deserve something better and that there is a next step. So that's not where they necessarily land and live for years. But once you've got a few months of rental history under your belt, where do you go from there to apply for the next option? But I think what I'm hearing in the question is also about, how do we maybe avoid that step? How do we go right from homelessness into an option that is better quality housing? And again, I think that's related to maybe partnering with some of our partners in community who have expertise in that housing search role. Because, like, Christina can maybe comment on all of the landlords and the partners that she has in her work. There is so many little landlords who we don't necessarily all know in our roles, and we don't have the time to form relationships. And landlords are looking for a relationship with support providers who they might be able to call if there's an issue coming up, or people that they kind of trust, like, you know, if this starts breaking down, there's somebody involved. And a lot of our housing search resources have spent the time building some of those resources, or building some of those relationships. So partnering with one of them, you might find some of the more hidden options for housing. But at the same time, our housing search resources are short term. They put somebody into housing and then their role is done. So that landlord is going to want to know, okay, who is the follow-up contact? Once your role ends, who do I call 3 months from now if this is breaking down? So it's a lot about communication, sort of trying to walk in each other's shoes, understand the different perspectives of being a support provider and a landlord, and building relationship and connection. Christina, do you have anything to add to that?
No, I think you nailed it. I think it really comes to what Mary Agnes Welch was saying. As a landlord, I hear from our members all the time. They say, I want to know who I call when something's going wrong. And there's a piece of us working with our sector to equip our landlords to get those supports, so that they have someone who can help to do some of that. But there's also a partnership there, and so the model that Mary Agnes is working on with in partnership with Rainbow Resource Center, that is the model of the future of social housing. It is the model that has been proven to work, where there's a partnership between a support organization that can support the needs of the folks living in the building, and a landlord and a builder developer who can do the property management side of things. Those models tend to be quite successful. The other big gap that we have, and I see in the question for Jessica, is like, are there going to be new buildings with this support? And we would say, we sure hope so, and we need to advocate together for that. So in many provinces, housing is built where there is funding from health for the supports. There are on-site 24-hour supports, or even at least 8-hour supports. Some of those are clinical supports. Some of those are just the supports like a case manager who can point people to resources. And then there's the housing side that's paying for the housing. And those models are what works. And we as two sectors that don't necessarily work together but are helping the same people should be advocating for more and more of that, because that's really the huge gap in Manitoba for those in the highest needs.
Thank you so much. So we're coming towards the end here. So I'm going to do one last thing where we're going to just take 1 minute or less. I'm going to ask each of you, what is one thing that you would like to see focused on over the next 12 months, given the improving mood of the federal, provincial, and I guess, you know, to some extent, municipal kind of climate for doing something. So Christina, one thing that you'd like to see in the next 12 months either done or you plan to do?
I would love to see our sectors and funders all working together on housing development. So right now, the municipality has funding and is interested in housing and homelessness. The province is back in the game. The federal government is there, and they all have their own programs. So let's put them together and work with the nonprofit sector, with health and with housing, and we can all work together to build those models.
We'll get to that 1,000 units in a year. All right, Hyung.
I mean, I think when it comes to the direction in housing policy, I rely on the expertise of people like Christina. But I do want to see a direction that we go where we recognize the needs of the population that have equity challenges of even obtaining housing, and realizing that the housing market will not solve the problem. And again, I do agree that we are kind of at this interesting state where all 3 levels of government are actually interested in the issue, and hopefully they actually take it in the right direction and don't take the right direction and look for the solutions that anyone working in this area who has an interest in housing issues, including housing and health, housing and equity, housing models, those solutions are known. So hopefully those decision makers take the advice and expertise of the people who understand the policies and the real solutions, and take it in the right direction.
Excellent. Mary Agnes.
Yeah, in addition to sort of bringing together the health and social service networks to work a bit more closely with landlords, the one thing I'm really looking forward to in the next year is something the city, I think, is working on, and that's this idea of a housing concierge at City Hall, to help maybe two willing partners who might have the start of that model, the housing provider and the kind of the social agency, to help them build a project, work out all the nightmare of bureaucracy and stuff that you have to go through to get a project built. So that, I think that could foment some of these little partnerships that I think are the key.
Mary Agnes, you know, my 25 plus years, I reflect back on Winnipeg's single window initiative, the WHHI model, which brought the 3 levels of government and everybody together to do exactly that, to eliminate all these. Anyways, Shannon, the last word, the last thought.
I think one of the things that comes to mind is with the programs that are provincially supported, a lot of them were designed and created at a time when our community was in a different place. And the support needs of individuals right now are different. And the program model design hasn't necessarily kept up with that. So I think taking a look at caseload sizes, program design based on acuity of the level of needs that people are experiencing in those programs would create some of the stress that staff, like would address some of the stress that staff in various programs, both community and system-wide, are experiencing when they feel like they're providing support to people with the highest level of acuity, but their caseloads are super high in having to do that.
That's wonderful. Well, listen, again, I want to extend a great, huge thanks to our panelists for taking time. Christina, certainly for tuning in from the coast and probably taking time out of some important sessions or mix and mingle events in the evening there. Mary Agnes, I know that you're not feeling 100%, so take care of yourself. And to everyone for attending, thank you so much. It's been a pleasure to host. I've taken so many notes for my class and my own thinking, so I always learn more than I know from these events. So take care, everyone, and I'll let you all log out as you do by pressing the red button. So thanks, everyone.